Today, President Cyril Ramaphosa signed the National Health Insurance into law. Let's dissect this. And this is how we're going to look at it. We're going to look at the details of the law. We're going to look at the problem and do a problem analysis, look at the promise of the National Health Insurance Act, look at the principles involved, and then look at the bill. Is this affordable? Can South Africa do this? Then we're going to look at the gaps, if there are any gaps, the pushback, whether it's legitimate or illegitimate, and the political calculations. So that's going to be the sequence of this discussion today.
Okay, if we may please sit it because we're blocking the view of the cameras at the back. This is a live event.
I'm signing here. I hereby, in terms of Section 84.2, read with Section 79.1 of the Constitution of the Republic of South Africa 1996, assent to the National Health Insurance Act of 2023, Act number 20, and sign the English text thereof, given under my hand at Pretoria on this day, 2024. So I sign where it's written President. I then sign where the act has to be assented to.
So, looking at the details of the Act, the purpose of the Act, as stated by the Act, is to establish and maintain a national health insurance fund in the Republic funded through mandatory prepayment that aims to achieve sustainable and affordable universal access to quality healthcare services by A, serving as a single purchaser and single payer of healthcare services in order to ensure the equitable and fair distribution and use of healthcare services, B, ensuring the sustainability of funding for healthcare services within the Republic, and C, providing for equity and efficiency in funding by pooling of funds and strategic purchasing of healthcare services, medicine, healthcare goods, and health-related products from accredited and contracted healthcare service providers. Application of this particular Act. The Act applies to all health establishments, excluding military health services and establishment. The Act does not apply to members of the National Defence Force, the State Security Agency. 3. If any conflict relating to the matters dealt with in this Act arises between this Act and the provisions of any other law, except for the Constitution and the Public Finance Management Act, or any Act expressly amending this Act, the provisions of this Act prevail. 4. The Act does not in any way amend, change, or affect the funding and functions of any organs of state in respect to healthcare services until legislation contemplated in sections 77 and 214, read with section 227 of the Constitution, and any other relevant legislation have been enacted or amended. 5. The fund is exempt from the Competition Act 1998 to enable it to fulfill its mandate as a single purchaser and single payer as contemplated in Section 2. Now, this could be a cause of a constitutional challenge. More on that later. Coverage. Who gets covered by the National Health Insurance Act? The fund, in consultation with the minister, must purchase healthcare services determined by the Benefits Advisory Committee on behalf of A, South African citizens, B, permanent residents, C, refugees, D, inmates, as provided for in Section 12 of the Correctional Services Act, E, certain categories or individual foreigners determined by the Minister of Home Affairs after consultation with the Minister of Finance and by notice in the Gazette. An asylum seeker or illegal foreigner is only entitled to the following: A, emergency services, B, services for notifiable conditions of public health concern, And then all children, including children of asylum seekers or illegal foreigners, are entitled to basic healthcare services as provided for in Section 28(1)(c) of the Constitution. A person seeking healthcare services from an accredited healthcare service provider or health establishment must be registered as a user of the fund as provided for in Section 5 and must present proof of identity to the healthcare service provider or health establishment in order to secure the health service benefits to which he or she is entitled. Number 5, a foreigner visiting the Republic for any purpose, A, must have travel insurance to receive healthcare services under the relevant travel insurance contract or policy, and B, a foreigner who does not have travel insurance contract or policy referred to in the paragraph has the right to certain healthcare services as contemplated in subsection 2. And those are the same ones that I think apply to illegal foreigners and asylum seekers, right? So which is emergency services, etc. So those are the details of the Act. So what is this NHI? Fundamentally, the National Health Insurance is a health fund. It's a prepayment system that allows for a pooling of funds, a pooling of risks, and therefore allows for economies of scale in purchasing drugs, paying service providers, that kind of a thing. And basically, it's medical aid, but for the whole country. And the current system of medical aid is such that money is allocated from the national purse, and that is directed towards healthcare expenditure by the state, but there isn't a prepayment system to increase the size of that wallet so as to allow for economies of scale and other things, right? So we've covered the details. What is the problem? The problem as it exists in South Africa is that there's a lack of access to healthcare. And also there's an unequal healthcare system by race, by class, and by location. Here are the numbers if you're interested. 75% of Black South Africans, and 56.1 coloreds rely on the public health sector service today. So 75.5 Black people, 56.1 colored people rely on the public healthcare system. In contrast, 83.4% of white people and 65.5% of Indians utilize the private healthcare sector, right? So that deals with access by race. Then when it comes to access by geographic location, 43.6% of South Africans live in rural areas, but rural areas are only serviced by 12% of doctors and 19% of nurses in the public sector, right? So you can see that there are discrepancies to access to what we may call quality healthcare on the basis of race, on the basis of location. But these are the access issues. What about the quality issues, quality of health in South Africa, right? So there is a low life expectancy in South Africa compared to other countries in the G20 or in the OECD, for example. The life expectancy at birth was estimated to be 59.3 for males and 64.6 for females, and that is for 2021. The infant mortality rate for 2021 was 24.1 per thousand live deaths, right? So what is the other issue? Right? I'm just looking at my notes. What is the other issue? The other issue is that there are high numbers of non-communicable diseases, high numbers of communicable diseases, and also high numbers of non-natural deaths in South Africa. And the quadruple burden that is facing South Africa relates to the following: diseases such as tuberculosis, maternal and child morbidity and mortality. Number 3, non-communicable diseases mainly related to lifestyle. This is diabetes mellitus, violence, injuries, and trauma. What is the promise? The promise of the NHI, you saw that video by Panyaza Lesufi saying to people that they'll be able to get any healthcare at any private hospital because the state will be able to pay for that, right? That's the promise.
After E29 Zagabe, after Sifojini ANC Lomteto Uti, you can go to any hospital of your choice. Whether it's a private hospital or it's a public hospital or it's a private clinic, ungene uhamba nje go any private hospital and get the best experts to come and treat you. After treating you, the government will pay that bill free of charge. The better knows to do a national non-employed NHI. That's why we are saying to our people, go and vote for the ANC for it. That God are the days, Mama, now your medical aid, you must die. God are the days, Mama, now your medical aid, you must be mistreated in our hospital. God are the days, Mama, now your medical aid, you are even scared to go to hospital. We are saying after the 29th, that's the end. We'll have one medical aid for everyone, whether you are working or not working. You are old or young.
Oh no. Ah.
That's what you are saying, 829.
But at a deeper level, what are the aims and objectives of South African policymakers? The National Planning Commission in 2011 said the following: increase the life expectancy of South Africans to at least 70 years, produce a generation of under 20s that is largely free of HIV, and achieve an infant mortality rate of less than 20 deaths per 1,000 live births, which is including an under 5 mortality rate of less than 30 per 1,000. So these are the hard objectives, in business and policy, we often refer to something which is known as OKRs, objectives and key results. So these are the objectives and key results. So let's examine now the principles that are at stake in this particular conversation. Number one is just the constitutional yardstick, right? Health is a right as articulated by Section 27 of the Constitution, which states that, you have a right to healthcare, food, water, and social security. 27.1, everyone has the right to have access to healthcare services, including reproductive healthcare. And then that's 27.1a. Then 27.2, the state must take reasonable legislative and other measures within its available resources to achieve the progressive realization of each of these rights. Number 3, no one may be refused emergency medical treatment. Now, that is the constitutional provision that protects and provides this particular right. At a second level, at a principle level, the argument is that healthcare is a public good, and at a third level, that unjust systems of distribution of benefits in society should be dismantled and restructured. A public good is a commodity or service that is provided to all members of the public by the government. And the idea behind public goods is that there is a net benefit to providing these particular commodities, goods to the public, and that helps the nation overall. And also that private actors are not going to be able to efficiently provide these services to everyone or provide them without there being significant market failures, like failing to provide a certain quality to certain people. So that is the principal argument around healthcare is a public good. So if healthcare is a public good, what you want to do is make sure that it is in the hands of the state, because the state is the best actor to provide that. In the hands of private players, what can sometimes happen is that the price can go up, the quality delivered to marginalized communities, be they rural, be they indigent and rural, is often inferior quality and sometimes may be abusive and or coercive, or just that it may be a zero altogether. Right? So that is the argument on the principle. The argument around the idea of unjust systems of distribution should be dismantled is that the healthcare system that currently exists in South Africa was largely inherited from the apartheid system, where you had, towards the end of the apartheid era, a deregulation of private healthcare sector, which allowed for certain companies to be formed to take advantage of that deregulation and to be in a strategic position when South Africa attained freedom. Post 1994, what then happened is that those particular companies basically took over and replicated some of the apparatus of the apartheid system, and then you have a healthcare system which provides excellently and at a global level in the private healthcare sector, and then you have a system that provides with challenges of execution in the public healthcare sector. Furthermore, just so you know, 16% of the population uses the private healthcare sector, and 84% of the population uses the public healthcare sector. Okay, so let's discuss budget. Oh yeah, let's backtrack a bit before we discuss budget. So if the private healthcare sector is a replica of apartheid healthcare, and if it is an inheritor of the apartheid healthcare structure, the argument is that 1, that is unjust, 2, that is inequitable, and 3, that there are grounds, therefore, to dismantle and restructure it in a way that allows for more people to be able to access healthcare, because the apartheid healthcare infrastructure was racist by design, and anything that perpetuates that racism is therefore morally unjustified, and policymakers are justified then to remove it. That's the argument in principle around that. Okay, so we've addressed that. Now going to the bill in terms of costs. The bill, who's going to pay the bill? Right. Currently, the healthcare system is funded by the National Revenue Fund. The National Revenue Fund in South Africa is a fund that receives all money which is raised by government, including taxes, fines, and donations. Right. The cost of healthcare overall is 627 billion, which amounts to 8.9% of the GDP per year. The national healthcare budget in 2024 was 271 billion, which translates to about 450 rands cover per person per month. Now, how much does medical aid cover cost in the private healthcare system? It costs at the lowest end around 2,300, but on the higher end can actually cost 12,000 rand per month. I spoke to some people preparing for this discussion. Some people are paying 4,000 for themselves, 2,000 for their children. Some people are paying for 3 kids and a wife, and so the numbers vary. But the lowest you can get is 2,300, but it can go up as high as 12,000 per month. The cost estimate for the lowest cost version of the NHI from the government is around 500 billion. So you can see that there's a shortfall there of 230 billion in the current funding structure, right? My calculations based on looking at the projections from the socio-economic impact assessment system was that actually the healthcare insurance could actually cost for full coverage between 1.5 trillion and 1.9 trillion. And I'll just do the calculation somewhere if you're interested, maybe at the end of the video, just so you can see how I got that number. So by many estimates right now, what the NHI will provide will be a cover of 715 rand per month per person, as opposed to the 450 currently. And I must check that. I think it's per month, not per year. But anyway, in any event, those are the numbers. Big difference between the current 450 and the 715 that will be provided. And also a big difference between the 715 that you get on the national health insurance as compared to the 2,300. Now, the structure is such that there needs to be funding to cover that shortfall. And what the socio-economic impact assessment report said is that this is how it's going to be funded. For employers and employees, they will be subject to an NHI-specific tax. For high-income earners, capital income earners, and unincorporated businesses and corporates, they will be subject to corporate income tax, surcharge on taxable income, which includes interest and profits in the case of unincorporated businesses, and also inheritance tax. So these are the funding mechanisms. Now, there's been some reporting which has been done, which then indicates that people who are in the formal employment sector may have to pay up to 1,500 in addition to all of their other taxable income right now. So definitely a tax increase to cover that. So what are the gaps as they pertain to this particular policy, right? So here are some of the gaps. The official statistics say that there are 36,900 doctors in South Africa. But Econex, which is a research firm, has said that there are about 27,000 doctors practicing in South Africa. 17,000 are general practitioners, 9,600 are specialists. Even if you use the number 40,000 to cover this, there's a big discrepancy in the numbers per 10,000 people between South Africa and other countries which have national healthcare insurance or a national healthcare service. So here are the numbers. Doctors per 10,000 people. In the United Kingdom, you have 32 doctors per 10,000 people. In South Africa, you have 8 doctors per 10,000 people. In Canada, you have 25 doctors per 10,000 people. In Australia, you have 41 doctors per 10,000 people. In the European Union, you have 43 doctors per 10,000 people. And the source for these numbers is the World Bank. So when you then consider this, South Africa has a large shortage of doctors and nurses, meaning that it becomes very prone to doctors and nurses exercising their right to walk off and look for greener pastures if there's instability introduced into the system. When we look at the United Kingdom as a case study.
Why are so many people leaving the NHS? It is a complex organisation, so it is a complex answer, but the data shows us some of the various reasons. Let's start with work-life balance. This chart shows people who've left the service on top of what we'd expect if resignation rates had stayed the same. And you can see that work-life balance in red is well over and above the other reasons, relocation or health, for example, with that increase costing the NHS 10,000 staff last year. Staff across the NHS now 3 times more likely to quit due to work-life balance than they were a decade ago. And we can see that strain in another set of figures. People taking time off work due to stress, anxiety, or depression. That is a 56% increase since 2015, nearly 500,000 days off for mental health, or 1 in every 80 working days. So a worse work-life balance, worse mental health problems, and on top of that, less pay. For example, adjusting for inflation over the last 10 years, a nursing assistant's pay has been pretty flat. But compare that with a switchboard operator or a warehouse worker, their pay going up, you can see why some NHS workers might consider moving jobs. And Brexit is another reason the NHS has been losing staff. A recent study by the Nuffield Trust found the number of European health workers moving to the UK has declined steeply since the 2016 referendum. Now, for some areas like nursing, it's managed to fill those gaps from outside the EU. But it is a different story for some medical specialisms like surgeons. In the years since Brexit, the number of doctors recruited from every sector here, the EU and elsewhere is less than it was before, but much less from that blue of the European Union. The UK is training more new recruits at home, though. It has been for a while. For the last 2 decades, the UK has produced more medical graduates than the average OECD country. Yet it still lags behind in terms of practicing doctors per population. And that's mainly because of lack of training posts after graduation. And leave you with this, which shows the growing problem. We hear about more doctors adding, the workforce expanding, and it has by 179,000 in the last 4 years. But the growing demands that there is this gap. And that gap is why we have a crisis, because vacancies are rising, not falling.
What has been happening in the United Kingdom is that junior doctors have been leaving the medical profession, some leaving to other professions, others have been leaving to go to Canada and Australia, where the pay is significantly higher than the United Kingdom, right? And UK doctors, junior doctors earn about 41,000 rands per month, depending on the number of hours they work. If they work about 40 hours, that's how much they're going to make. But they can make significantly more than that if they add hours. But there have been some doctors who've made videos showing that this is how much they make. So it's not very high, as you can see, even if you convert it to rands. £1,800 is the number per month. So they've started leaving the profession because they have student loans and they feel that their income is not matching their interest payments and other lifestyle decisions that they may have to make. Now, that is in the UK, which is a fully functional healthcare system, but it is now facing challenges. There are people who have waiting times for months to meet a specialist. So generally you meet a GP, then you get referred to a specialist if you need a procedure, if you need to consult, but you need to have an appointment set up for you. So what's happening now is that the waiting times are getting longer and longer and longer. And at the same time, people are saying that they're being discharged earlier from the hospitals before they're fully recovered because the hospitals need the beds. This is what the patients are saying. So the UK healthcare system currently is under a lot of strain. And note, the UK has 32 doctors per 10,000 people, whereas South Africa has 8 doctors per 10,000 people. So if the UK is struggling with its healthcare system, is it unreasonable to assume that South Africa cannot provide the same NHS, which is what it's called in the UK, experience to South Africa because of the challenges in manpower as things stand right now? So that's the first gap that people have been pointing out. The second gap is that the affordability gap, that South Africa has a massive shortfall as things stand between the current expenditure on healthcare and the desired expenditure. If you recall, I say to you that the number projected by the government to roll this out is 500 billion, but to actually effectively roll it out, you need multiples of that. So where's that money going to come from? Even if you do increase the tax, you're not going to be able to cover the full costs of fully covering 62 million people. So there's that particular issue as well. So if there's a challenge with affordability, what may happen, and this then pertains back to the doctors, is that if you are running out of money, people may start not getting paid on time or not getting paid a fair wage or what they think they deserve. As you continue to see the cost of living going up year on year, the cost of housing going up year on year, there may be doctors who feel like, I'm not being paid on time, I'm working in a hostile environment in terms of the equipment is not fully functional, not fully there all the time, and those doctors may decide to leave and go to Canada, Australia, America, and many other places which are offering South African doctors who are very well trained these opportunities. So that's something that's worth considering. Then the other issue is that there have been multiple corruption scandals in the healthcare sector. If you remember with Tembisa Hospital, 500 million rands was looted from the hospital's coffers and from basically Gauteng. And all of that was done through these fraudulent invoices. And they said that money was being spent to buy skinny jeans, etc. But, healthcare analysts have actually said that a lot of that was just fabricated stuff. Even the jeans were not bought. The money was just being looted. There have been late payments to contractors across the procurement system, the government procurement system. Many small business owners have reported not being paid for 90 days or longer. So that's something that's worth considering. Then the track record, in some instances, if you recall, Life Esetimeni, so many people died because of poor healthcare provision in that particular mental health facility. And, that was something that was very prominent and many people will remember that. So when you then consider a lot of these dynamics, as well as the fact that, money was looted during the COVID pandemic, money was looted for masks, money was looted in school fumigation programs. If you recall the reporting on that, there were those ambulances that were on motorbikes that were purchased. There was a lot that was being done which wasn't entirely sensible and didn't seem entirely prudent from a financial perspective. So that's something that then leads to concern about the capacity of the ANC government to roll this out, if they are the practitioners to roll it out, without there being a lot of challenges. In the actual socio-economic impact assessment, what government said was the following. Government will implement various measures to effectively control costs and to ensure that the NHI remains sustainable and affordable, right? The cost containment measures implemented will address both supply side and demand side constraints while ensuring that providers are fairly reimbursed for health services provided without compromising the quality of care rendered to the population as outlined. This is a very big promise, which just doesn't seem like it's likely to occur simply because of everything else that has occurred thus far. Various measures to effectively control costs. we have seen multiple projects increase in cost, and we've seen that from like the scandal with Tembisa Hospital, that there hasn't been a culture thus far of cost management. And also the Auditor General report has made scathing findings against the Department of Health in and of itself. So this promise is a big leap and a big assumption in the NHI model and socio-economic impact, that somehow the government will be able to retain the costs and to prevent corruption and all of the stuff that is currently happening. The big issue is that there's a trust deficit between the public and the government when it comes to this. And this is what is making people concerned, because they are worried about losing their healthcare. They are worried about the implications to their families. People have got family members with hypertension. People have got family members who've had strokes. People have got family members with diabetes. People have had family members with long COVID, and they're really concerned whether or not their family members will be able to access healthcare on time, at quality, and actually be able to live. Sometimes that is the difference. If you are able to get into a good hospital, you'll live. And if you don't get good quality emergency services, you may die. And that is the reality. That's why people sometimes, depending on the condition, are afraid to go to public hospitals. So that's the discussion around that. Now, there are political calculations which we need to discuss, and this is going to be the landing pad, so to speak, of this video. The timing of this announcement is 2 weeks before elections, and that cannot be ignored. The president had this bill on his desk for several months, and he was not assigning it. He was saying that, listen, my pen, I'm looking for my pen, etc., waiting for my pen to get ready. Well, finally, he signed today, 2 weeks, and the way that he signed was novel. And what do I mean by this? Typically, when the president signs a bill, you never see it. It's never televised. It's never documented in this kind of a public way. But this particular signature was done with cameras, with dignitaries, with full media there, and for full media attention and effect, right? A very Trump style, very Obama American style signing of a bill. And, it is partly for the show. And it can therefore not be ignored that this is being done at this particular time with a political calculation in mind. What could be that political calculation? As I outlined earlier, rural communities do not have the same access to healthcare. And as I outlined earlier as well, Black and colored people do not have the same access to healthcare as white people and Indian and Asian people in South Africa. So this could be in part to try to get some support from the majority Black population by showing that, the ANC and President Ramaphosa are willing to fight this fight for them. And the timing at this particular point and the fact that, it's so close to the election could be viewed as something that could be strategically beneficial, because there are going to be particular pushbacks. We've seen the Democratic Alliance pushing back, and because of the racial dynamics of different parties, that can then introduce different elements of conflict, which may be favorable towards the ANC as the party that is the one that is fighting in this particular instance for healthcare for the majority. Now, obviously, healthcare, universal healthcare, is a noble cause, and it's something that everyone should have. And obviously, many people are out of the gap. Some people are not thinking about healthcare right now because they're young, they're healthy, but it's a big issue, and you begin to see how big of an issue it can be when you get sick and they start telling you how much things cost, right? But did I discuss this before? I think I did. But when you then consider, I don't think I mentioned it, I think I skipped over it, but it is something that has to be discussed in terms of the gaps. The other gap that exists is that the diseases on the demand side, right, the leading killers in South Africa, tuberculosis, diabetes, heart conditions, and HIV, all of these things, not HIV, let's leave out HIV, tuberculosis, heart diseases, diabetes, some of these are lifestyle diseases. as a result of obesity, as a result of alcohol consumption, as a result of lack of exercise, access to gym facilities, that kind of a thing for adult South Africans. So even if you are able to execute this, if you have 15, 20 million people who are sick or in need of healthcare, the system is not going to be able to sustain that healthcare supply. And then you therefore need to then be honest about that. So the NHI Act, even if it was done perfectly, would still not deal with the fact that you have these challenges with diabetes, you have these challenges with obesity, you have these challenges with alcohol consumption, you have these challenges with some of the communicable diseases, but also you have challenges around non-natural deaths. If you recall, in the last year, 27,000 people died from murder. And that's a large percentage of the 450,000 people who die per year in South Africa on average. So those kind of things are not necessarily going to be addressed through the National Healthcare Act, the demand side. So on the supply side, you're going to have challenges, especially if the doctors decide to leave because they don't trust the ANC to do this, because they get better offers, or because the system doesn't work as they thought it would work. All of those will cause challenges. But also on the demand side, there's this big issue of not dealing with the lifestyle issues that are causing these chronic illnesses that are beginning to become a large part of the disease burden in South Africa and also in many other low, medium income states, right? So that's something. So this is where things are right now. Many political parties such as the DA say that they're going to challenge this. And if you recall, this act exempts the NHI from the Competition Act, and there may very well be a challenge there as well to say that is something that should not happen and may even be unconstitutional. So it looks like there will definitely be some resistance. We've seen the healthcare insurance providers issuing through the media different critiques of the NHI and raising challenges to the NHI as well. So this is a preliminary phase of this particular discussion, and these are the dynamics. I hope this video helped you understand all of the different elements and that you're beginning to form your own view around where you stand. And I'm curious, do you support the NHI? Are you worried about the ANC being a practitioner of an NHI system? Or do you fully oppose the NHI? Do you work in the healthcare sector? Do you have views that you would like to share with us? Let's have a conversation. I'm interested to hear what you have to say. Till the next one.